Thank you.
Good morning. Thank you for this kind invitation. So, no conflict of interest. We have realized that the right-sided valves are often neglected. Guidelines are less definitive, and the significance can be underappreciated on imaging also, and management is complicated and dependent on mechanism. So we have already discussed the new appreciation of complex anatomy of a tricuspid valve according to the Rebecca Hahn. And we know that the 50% of patients with tricuspid regurgitation have 3 leaflets, and the rest of them have 2, 4, or 5 leaflets. So a little bit more anatomical data. We have already discussed that the tricuspid valve annular has a saddle shape and has a more than 20% change in area during cardiac cycle. And we have already realized that the tricuspid valve annulus is a virtual annulus. It's not a fibrous one and has a smooth transition from atrium to ventricle. Tricuspid etiology, more frequent, secondary TR 80 to 85%, primary TR 10%, and 5 to 10% pacemaker lead interference. And we know that the tricuspid regurgitation is associated with increased mortality dependent on pulmonary pressures and right heart failure. And we have already realized that at least moderate TR is independently associated with increased mortality, not only in hospitalized patients, but all comers patients. So we have better understanding the anatomy and pathophysiology of tricuspid regurgitation. And this is an old slide demonstrates the historical thinking of tricuspid annulus. And we know that annular diameter of 70 millimeters measured interoperatively from the anterior septal commissure to the anterior posterior commissure correlates to the diameter of transthoracic echocardiography from an apical four-chamber view, and we measured as 40 millimeters. We have discussed for the different tricuspid secondary tricuspid regurgitation, and we realized that ventricular secondary tricuspid regurgitation, all these patients have less annular enlargement and theoretically better leaflet coverage, but more RV lengthening and eccentricity compared to the atrial functional TR. And a single 2D diameter cannot fully describe tricuspid annulus geometry. We need a 3D echo just to demonstrate all the anatomical data of tricuspid annulus. And we have already demonstrated that ventricular tricuspid regurgitation and atrial functional regurgitation have not only different clinical and morphological characteristics, but also different echocardiographic characteristics. Tethering is more severe in patients with ventricular functional tricuspid regurgitation compared to atrial. And we see that the tenting height, tenting area, and tenting volume are higher compared to patients with atrial function regurgitation. And it's very important to present that end-systolic right atrium to right ventricle area ratio is less than 1.5 in patients with ventricular function tricuspid regurgitation compared to atrial function. There is a good correlation between tricuspid annulus area and right heart chambers. Annulus area, as demonstrated by 3D, was more closely correlated to right atrium volume than the right ventricular volume. And right atrium maximum volume was the most important predictor of tricuspid annulus size, accounting for 58% of tricuspid annulus area variance. Regarding atrial functional tricuspid regurgitation, it's very important to present that the larger RA area and the RA to RV area ratio were independent risk factors for significant atrial functional regurgitation. This slide has already presented functional as atrial or ventricular tricuspid regurgitation, device-related regurgitation, and 2 to 5% organic primary regurgitation. The previous slide demonstrated the phenotype, or the different phenotypes of tricuspid valve regurgitation, but this slide demonstrates the phenoclusters of patients with severe tricuspid regurgitation, incorporated many other parameters, are renal, hepatic function, LV function, and many other laboratory and clinical parameters. And we realized that all of these clusters have similar 5-year composite death and major events. Let's move to some important topographic landmarks of tricuspid valve commissures and leaflets. And when we depict the tricuspid valve, we have to depict the coronary sinus and the anterior muscle. Different phenotypes of a tricuspid valve with 3, 2, 4, or 5 leaflets, and the tricuspid annulus anatomy. Using transesophageal echocardiography, we can depict the anatomy of the tricuspid valve at the mid-esophageal, deep esophageal, and tricuspid views. Tricuspid view is very useful view. It gives the tricuspid valve a short axis, and we do the procedure, TEER procedure, using just only transesophageal, deep transesophageal views. These are the different anatomical data when we prepare a patient and when we assess the eligibility of for tricuspid TEER procedure. Coaptation gap less than 7 millimeter, anteroseptal jet, the leaflet morphology, and the right ventricular function are good. Right ventricular function are favorable echocardiographic data, and favorable data were larger coaptation gap and anteroposterior jet. Not only anatomical factors, but also center experience involved in the decision to perform TEER procedure. I would skip this. It's very important to evaluate the post-TEER procedure residual TR. We have to use all the advanced echo techniques and also CMR, but we have many difficulties in evaluation of residual TR. because vena contracta adding multiple jets has not validated. Abnormal shape of proximal flow may result in Pisa radius, in overestimation of Pisa radius. And we try to use 3D in order to evaluate the residual tricuspid valvular regurgitation. Rebecca Hahn suggested that the core imaging laboratories provide a standardized and homogenized evaluation, reducing variability and ensuring consistency across sites. Let's present a case, 83 years old woman with a huge V wave, atrial fibrillation, and you see before the procedure, TEER procedure, that this shape of LV, bilateral dilatation, particularly RA, and as RV wave 8 centimeter. You see that we categorized as massive tricuspid regurgitation with vena contracta with 17, Pisa radius 12, systolic hepatic vein reversal, PASP 15. The patient presented pseudoconstriction pattern due to loss of pericardium reserve. And this is transophageal views. You see the massive tricuspid regurgitation. And according to right and left heart cardiac catheterization before the procedure, the patient had not severe pulmonary hypertension, pseudoconstriction pattern of a deep plateau, and a guide V wave of severe tricuspid regurgitation. And we proceed to the TEER technique with one device implantation at the septal and anterior leaflet. And this is the pre- and post-procedure evaluation. You see that the residual moderate TR, RV positive remodeling. You see the difference, PASP of 30 millimeter of mercury, and no pseudoconstriction pattern. Another case with a detachment, single detachment of a device, and the second clip was implanted with mild residual. So, dear Chairman, ladies and gentlemen, we think that we have to evaluate the patients using all the imaging modalities before the TEER procedure, just to have the the excellent results. And we all know the true illuminate TR results of 2 years that demonstrates that quality control improved, and the patients have less hospitalization. But furthermore, the promise of AI must be tempered by the known biases of these methods, particularly for imaging modalities such as echocardiography, for diseases such as TR, specifically in which arrhythmias, respiratory phasic variability or image quality must be particularly problematic, but AI may help to identify phenogroups with different clinical risk profiles, and furthermore, computation remodeling, it may significantly improve our ability to understand tricuspid valve biomechanics and to predict the results of a planned intervention, and adding the right ventricle into computation models of TR will allow prediction of the short and long-term effects of tricuspid intervention on RV function. Thank you for your attention.
Thank you, Professor Aggeli, for the presentation. What is your screening method nowadays? Are you the one who decides if a patient is a good candidate for TEER in the tricuspid valve? Is it a heart team approach?
I think it's a heart team approach, and we discuss in every case. We're going to decide which procedure we have to select. According to the previous question, I think that we proceed to the evoke implantation in patients with good right ventricular function. We need to have good right ventricular function with a good right ventricular reserve function, and it's not necessary for the TEER procedure.
I was intrigued by your last two slides about AI involvement in the diagnosis and treatment of tricuspid regurgitation. Would you like to add anything more?
No, I just find a publication, and I think that we had to proceed to phenocluster of these patients because we have to evaluate not only the cardiovascular imaging data, but we have to incorporate also clinical, laboratory, and renal and liver function data, just to see which phenocluster of TR patients have a good prognosis or not.
Too many things for the human brain, so probably AI will be very helpful there. Like Thanos said earlier, tricuspid valve is so elusive valve, so you can have severe TR one day, and then after a few days with some medical interventions, it may be completely different. Preload, afterload, loading conditions, so many things that come into play, and so difficult also to predict the outcome, not only the anatomical, but also the clinical outcome after our intervention. So definitely I think there will be a lot of space in the AI field and the computational models you mentioned to help us in the future.
Yeah. Yeah. Thank you.
I don't know if there are any comments from Professor Kilic.
Thank you. Professor Aggeli, congratulations for the nice presentation. In one slide of Professor Aggeli, there was an answer of the question that which patients are suitable for transcatheter H2H therapy and which patients are suitable for transcatheter valve replacement. Especially the right ventricular function, TAPSE, the others are important, but could you open that slide maybe again? So what's your opinion again, the same question that Professor Sparger asked twice. It's very important for us that which patients are suitable for TEER and which patients are suitable for transcatheter tricuspid valve replacement.
Okay.
In one slide, it's very, you summarize it, the back.
Yeah, we have presented several times the favorable and not favorable anatomical data. And the center experience also plays a crucial role. And of course, the precise evaluation of RV function. This is my opinion.
Okay, thank you very much, Professor Aggeli.